Of everyone who has MASLD, 20% have the more aggressive form, which is Metabolic Dysfunction-Associated Steatohepatitis, which is MASH. But essentially, there's a more aggressive form where it's not just fat buildup in the liver, but there's associated inflammation and liver cell damage with scarring. So of everyone with the simple steatosis or MASLD, 20% will have the more aggressive form. And everyone of the aggressive form, only a subset of those get cirrhosis.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Welcome to another Monday. Our guest today is Dr. Monica Tincopa. She is Assistant Professor of Medicine at University of California, San Diego School of Medicine. And she is going to talk to us about a topic which I feel is becoming relevant for cardiologists or providers who are taking care of people with cardiovascular disorders or cardiovascular diseases, because this particular disease entity, for lack of a better terminology or word, is a condition which has a lot of comorbidities which we see as cardiovascular disease caretakers or providers. And the topic of our discussion is MASLD. It used to be called NAFLD, so non-alcoholic fatty liver disease, or NAFLD is now referred to as MASLD, which is Metabolic Dysfunction-Associated Steatotic liver disease. So with that introduction, without much further ado, I'll let the expert speak on the topic. Monica, thank you so much for doing this for us. Welcome on the show. Welcome to Parallax.
Thank you so much for this opportunity. It's always great to get the word out about why this condition is so important for kind of non-primary care and non-hepatologists to be aware of.
Yeah, absolutely. So, I'm going to start by asking you, why change the name? Why? I think just about when I was getting used to non-alcoholic fatty liver disease, you guys have come up with an even more complex name, which is, I think it's sophisticated. I think it sounds pretty smart. It's Metabolic Dysfunction-Associated Steatotic liver disease. What's the verve? Or what's the story or the genesis behind renaming this?
Yeah, important question. And I agree with you. Part of the concern or challenge in this area is, disease awareness, whether it's from patient population or providers. And so changing the name of the condition added an extra level of complexity. But this has been an ongoing discussion actually for several years, and there's been a number of different iterations. But finally, actually in 2023, they did make the official change. So as you said, it used to be called non-alcoholic fatty liver disease, or NAFLD. And there were several different concerns about that terminology. So one of the main concerns was it was essentially an exclusionary term, so non-alcoholic. So by definition, you had to rule out that, alcohol use disorder. And they thought that it was perhaps not as helpful to have it as exclusionary as opposed to having kind of more of an inclusionary. So that's why we say metabolic dysfunction associated, to have much more of an emphasis on the fact that this is really driven by metabolic dysfunction, as opposed to it being a liver condition that is not associated with alcohol. So one of it is just kind of moving away from exclusionary terms. But the other really strong driver was concerns about the stigmatizing language. So a lot of kind of providers and patients had issue with the use of the term alcoholic, for obvious reasons. And then there was also some concerns about the use of the term fatty. So people have different kind of thoughts and feelings about the use of that terminology. So we've changed from fatty liver disease to using the term steatotic liver disease. So there are pros and cons to both. I think from a patient perspective, it's not immediately clear what you mean by steatotic. It's not a term that, many patients come across. And because they tend to be more familiar with the concept of fatty liver disease, sometimes when, explaining the condition or when you give them paperwork about this, it's not as easy for them to grasp, what condition do I actually have? Whereas fatty liver was pretty, straightforward. Oh, I have fat in my liver. But that was the other concern was, the use of the term fatty. And then really the third limitation we had with the prior nomenclature was that there was no overlap category. So what do I mean by that? So as I said, NAFLD was an exclusionary. So by definition, you could not have substantial alcohol use. So you either got put into one of two buckets, alcohol-associated liver disease or non-alcoholic fatty liver disease. And the reality is in real-world clinical practice, there are a substantial number of patients who have metabolic dysfunction, and they also drink at a level that doesn't qualify them for alcohol use disorder, but it's also not zero. And we know that some degree of alcohol use, even if it's not to the point of alcohol use disorder, confers risk in terms of liver disease. And so the prior nomenclature didn't have a subcategory of that disease. And so in this new nomenclature, kind of the umbrella term is called steatotic liver disease. There's a new category that's called MASLD, which means that you have both metabolic dysfunction as well as some characteristics of alcohol-associated liver disease. So it's a very long answer, but for several different reasons, we wanted to address kind of limitations of the prior nomenclature.
No, it's a fantastic response. So there are two components to this, right? It's metabolic dysfunction associated, steatotic. What if you only, and I sort of ask this because we, as I mentioned, in the beginning of the episode, that a lot of the risk factors for MASLD, intercept with the risk factors that we see in patients who have manifest or, clinical coronary artery disease or, within the spectrum of cardiovascular disorders. We see these risk factors, insulin resistance, for example. And so could it be that there are patients on this, like there is a spectrum of this disorder where you have metabolic dysfunction only and not steatosis, and then you go on to develop steatosis? And do you see the entire spectrum when you come up with this diagnosis, or do you sort of stage them based on risk factors and manifest disease?
Great question. And again, a lot of this is evolving. So it used to be that we didn't actually recommend screening for steatotic liver disease just because the risk factors were so common and we didn't have, specific liver-directed therapy for it, right? The recommendations were, minimize or completely avoid alcohol, eat healthy, exercise, lose weight. But things have changed now that we do have liver-directed therapy, which I'm sure we'll get into later. But essentially, there are current recommendations to screen for this condition that are prompted by the presence of metabolic risk factors, right? So yes, 100% patients who are primarily being seen in cardiology clinic likely have underlying steatotic liver disease. The estimates are in the United States that 30% of all adults have underlying MASLD. The vast majority of people do not know that they have that. And, kind of given the trends in obesity, it's projected that these prevalences will just continue to rise. So the long and short of it is yes, tons of patients who are primarily being seen in cardiology clinic likely have this underlying condition. So the current recommendation is if an individual has any of these risk factors, you should be screening them for underlying fatty liver disease. So to meet the definition for steatotic liver disease or fatty liver disease, you have to have evidence of fat buildup in the liver. So usually that requires imaging. The most common imaging is just an ultrasound. You can also see it on CT, you can see it on MRI. Very small percentage of patients will actually have a biopsy. But the vast majority of patients, they'll see their PCP or they'll see some other provider and there'll be some sort of concern about fatty liver disease. And usually they'll start with an ultrasound. And then the ultrasound will say, yes, there is evidence of fat buildup of the liver. And then from there, you kind of go down the risk stratification algorithm. Again, the reality is in most practices, it's not really being screened for. And what we've seen in studies is particularly in cardiology clinics, it's not kind of at the forefront of management, primarily because there's other, kind of focuses of their care. So it's much more really being screened in primary care clinics. And then the second most common area where we're really getting screening and referrals is usually in endocrinology. So patients who have kind of poorly controlled type 2 diabetes, just because the prevalence is so high and the incidence of actually more aggressive disease is highest in patients with type 2 diabetes. So those are really kind of the two areas where we're seeing screening and referrals. But yes, if you were to kind of survey the patients that you see in your cardiology clinic, probably a lot of them have it. To your other point, is it possible that somebody has a number of different metabolic risk factors and they don't actually have fatty liver disease? Yes, that's also possible. And why is that? We think probably some of it is genetics, but we know that, BMI and metabolic risk factors by themselves are not kind of direct kind of factors that can tell you likelihood of underlying MASLD or kind of the more aggressive form of the disease, which is MASH. Some of that has to do with just kind of where your body hangs on to fat, right? So fatty liver is more common in people who have visceral adiposity, whereas other people tend to gain weight and have kind of subcutaneous fat. And it's really individuals who tend to have visceral adiposity that get this condition. And the other thing that's interesting is there's a whole entity called lean MASLD. So people who tend to have less metabolic risk factors, but by definition don't have kind of overweight or obesity, but still have fat buildup in the liver. And again, we think some of that is genetics, but there's a lot of heterogeneity. And just because you have some of these metabolic risk factors doesn't directly mean that you also, or it doesn't automatically mean that you also have fatty liver disease.
Monica, thinking about how patients would reach you, right, in terms of some of the patients you see in clinic as consults for MASLD, there may be two pathways, and educate us or correct me if I'm wrong. One is someone suspects a patient to have MASLD because of the metabolic dysfunction that is demonstrable on their comprehensive metabolic panel, just basic screen with hemoglobin A1C or fasting blood glucose, some dyslipidemia. And then they may send those patients over to you with or without imaging to see if they should be quote unquote screened. I don't know if there's active screening involved here for MASLD. The other pathway may be that, someone got imaging and, turns out that MASLD was an innocent bystander, and because it was documented on an imaging report, whether it's CT, MR, or ultrasound, they now are having to see an expert like yourself because this was something that was documented as an incidental finding on imaging. Do you see patients from both ends of the spectrum? Did I get that right?
Yeah, so 100% spot on. So I would say by far and away, the most common ways that patients end up seeing us in hepatology clinic are one, they had kind of routine blood work or blood work for some other indication, and they were noted to have elevations in liver enzymes. Usually they'll come to us with an ultrasound first, but not always. Sometimes they're just referred because they have elevated liver enzymes, and we see them kind of for the evaluation of that clinical question. The second way is kind of, as you said, so people will get imaging for some sort of indication beyond just elevated liver enzymes, say they have abdominal pain, or from a cardiology perspective, actually, we see a decent amount of people who are having kind of cardiac imaging. Say they have like a CT coronary and they'll catch like the top of the liver and they'll comment that there's steatosis there. So they'll incidentally be noted to have steatosis on imaging that was done for another indication. And then those patients are referred. If you look at our guidelines, what we are recommending is that there's like an initial risk stratification, because of everyone who has, MASLD, it's actually only about 5% over the course of their disease history that'll develop end-stage liver disease. So, of everyone who has MASLD, 20% have the more aggressive form, which is metabolic dysfunction-associated steatohepatitis, which is MASH. Used to be NASH. It's a lot of alphabet soup, but essentially there's a more aggressive form where it's not just fat buildup in the liver, but there's associated inflammation and liver cell damage with scarring. So of everyone with the simple steatosis or MASLD, 20% will have the more aggressive form, and everyone of the aggressive form, only a subset of those get cirrhosis. So what we're trying to do is, from a population standpoint, because 30% of the adult population has it, it's not reasonable to have everyone seen in hepatology clinics. So the current recommendation from AASLD, which is our liver society, is to do an initial risk stratification. So what we're asking is, okay, you identify somebody who has fatty liver disease, which generally is on some sort of imaging. You do something called a FIB-4. So a FIB-4 is a calculation based on routine labs. So you need a platelet count, and then you need a hepatic panel, and it'll put you into one of three buckets: low risk, medium risk, or high risk. And we're saying individuals who have medium to high risk FIB-4, those are the individuals that should be sent on to GI or hepatology care. Again, it's been a challenge because, again, primary care are very, overworked. They have a lot of competing interests. So they either don't have the time or maybe they're not aware of, doing the FIB-4. So it's not very often that they'll risk stratify based off of that first, but it's getting better. But the initial recommendation is to do the FIB-4. And ultimately, ideally, that's who would kind of make it down the referral pathway. You're identified as having fatty liver disease, you get a FIB-4, you either have an intermediate or high risk FIB-4, and those are the patients that should be seen in clinic.
Excellent. So, Monica, I think for a cardiologist, because you mentioned coronary CT, and that is becoming, at least in my practice, is my diagnostic test of choice when it comes to risk stratification in patients who are low to intermediate risk for obstructive coronary disease. If a cardiologist sees steatosis on the CT report, I think when patients are coming to see us for primary prevention, right? So we are ordering a lipid panel, we are getting a comprehensive metabolic panel, we get hemoglobin A1C. More often than not, we get thyroid stimulating hormone, we get LP little a, lipoprotein little a. Sometimes you would get ApoB and ApoA1. From an intervention perspective, I mean, in addition to putting a referral in, which I do, I'm sure all of us do to see a hepatologist. What are some of do you start with lifestyle interventions? So if someone is coming in, they're asymptomatic and all they have is this biochemical dysfunction sort of documented objectively on blood reports and maybe on imaging. So I don't know. I don't even know if you can call it. It's sort of. I think a good analogy here is what we see as asymptomatic coronary calcium scores is probably what you see as MASLD with imaging evidence of steatosis, but the patient is asymptomatic. What do you do in terms of intervention? Do you start with lifestyle, which I'm assuming is the answer on the boards? It's like boards. You go cheap, so you pick. Lifestyle is the number one intervention, but other than lifestyle, which it sort of is an oxymoron because I think they've sort of struggled with lifestyle is the reason why they have steatosis and coronary calcium. What are some of the interventions that you may do as a clinician? In the office, do you prescribe any medications or do you screen further?
Yeah. So again, another great question, and this has really been a game changer in the past 2 years. So prior to 2024, we did not have any FDA-approved medications specific for the treatment of MASLD or MASH. And so, yes, before that time frame, it was essentially lifestyle recommendations. So healthy eating, regular exercise, weight loss. And the reason for that is the studies have shown, they enrolled patients lost weight. So 3 to 5% reduction in body weight will reduce steatosis. If you get to 7% weight reduction, you can improve steatosis and inflammation if you have inflammation. And if you get to 10%, you can resolve steatosis, inflammation, actually fibrosis. So the great thing about fatty liver disease is if you catch it early enough, it's completely reversible. Obviously, it's challenging to kind of meet and maintain those weight loss goals, but if we catch it early, completely reversible. The problem is as you said, it's asymptomatic, right? So the classic teaching, kind of the board's question is, MASLD is an asymptomatic condition. People, it doesn't really bother them, which is why so many people don't know they have it. In clinical practice, patients will report fatigue. Sometimes they also report this kind of like non-specific right upper quadrant pain, but by and large, it's asymptomatic. The problem with that is it's a kind of silent disease, very similar to hypertension. So over many decades, what can happen is people will develop scar tissue and they can progress to cirrhosis. So these patients who were never referred to hepatology, nothing was specifically done, they were told to do lifestyle stuff, which obviously is challenging. So we failed those patients because, either they were never diagnosed or they were told they had fatty liver disease and they're like, oh, it's a benign condition, don't worry about it. So yes, the kind of core of treatment is lifestyle interventions with all the things we talked about. But as I said, as of 2024, we had our first FDA-approved liver-directed pharmacotherapy, which is resmetirom or Rezdiffra, which is a thyroid hormone receptor beta agonist. So it has direct activity specific to the liver, and in clinical studies has shown to improve fibrosis and also resolve MASH. So that was a game changer. So now that was the first therapy. It is only FDA approved for people who have MASH. So again, the more aggressive form with at least stage 2 or stage 3 scarring. So if you have cirrhosis, you're not eligible. And if you have earlier stage disease, you're not eligible. But if you're in that kind of sweet spot, we can put you on this therapy. And as I said, the studies have shown as you maintain that therapy, you can reverse MASH and you can resolve fibrosis. Why is that important? Because we know that liver-related outcomes and overall mortality tracks directly with the degree of fibrosis. So the inflection point is at stage 2. So liver fibrosis goes from 0 to 4. 0 being no fibrosis, 4 meaning that you have scarring throughout the liver, you have cirrhosis, and F2 to 3 being in the middle. So as soon as you get to F2, that's where your outcomes worsen. So if we can give you a medication that can reverse scarring, that really will change your long-term clinical outcomes, both from a liver perspective and from another perspective. So that was the first therapy 2024. So just August of this year, now we have a second FDA-approved medication, again, only for MASH with stage 2 to 3 fibrosis. That's semaglutide. So now we have a second agent that's approved, again, only for people with those specific indications. And the reason that that's also exciting is, these patients have these other metabolic conditions, and semaglutide and incretin therapy obviously is used for diabetes, is used for weight loss. It's had other kind of metabolic benefits. And so now that's a second option we have for these patients. But again, they're only for people who have that degree of liver disease. So theoretically, people should be screened and diagnosed with MASLD. They should then undergo the risk stratification, and those who have kind of intermediate to high risk scores should come to us, and we would prescribe them the liver-directed therapy.
So the first step, after you said lifestyle, is medication. So I'm assuming it's a PO medication that is. It's a prescription. Is it once daily? Is it twice daily? Tell us how you initiate these patients on this particular medication.
Resdifra or resmetirom is an oral medication, but the semaglutide, similar to kind of administration for other conditions, that one is actually an injection. There are other forms that are oral, but the one that's FDA approved for MASH with stage 2 to 3 fibrosis is injection form. But again, I think part of the challenge is it's not for everyone, right? So it's only for that very specific patient who has a more aggressive form of the disease with some degree of scarring, but not too much scarring. So a lot of what we do, once patients get to us is answering this initial question, do you have MASH and how much scarring do you have? Because in reality, of all of the patients that get referred to my clinic, only a very small percentage of patients actually meet the criteria to be started on one of these two medications.
Understood. Let's explore the intersection of MASLD and cardiovascular diseases. I have two questions for you. One, I know we use a lot of semaglutide therapy also for our patients because there is outcome data when it comes to incident cardiovascular disease, and there is an indication for our patients to use semaglutides. Just in terms of subcutaneous injections weekly. When it comes to some of the other medications that you mentioned, are there any specific drug-drug interactions in patients who have underlying cardiovascular disease that you want to educate us on, or have been deterring a barrier or a deterrence to prescribing some of these newer agents that you mentioned?
Yeah, I would not say that drug-drug interactions have been a predominant limitation to the prescription. I mean, resmetirom, the real benefit to it is that, again, it's oral. So it's easy to administer. There are not a lot of kind of contraindications unless you have, some thyroid history in terms of like higher risk for thyroid cancer, if you have pancreatic or biliary history. But for the most part, resmetirom, if you meet the diagnostic criteria in terms of MASH with stage 2 to 3 fibrosis, not a lot of concerns in terms of drug-drug interactions or other contraindications of starting it. Generally, it's very well tolerated too, so the side effect profile is very favorable. Semaglutide, as I'm sure kind of because we know from indications for a lot of other conditions, where we run into trouble with that is really side effect profile, tolerability, and access. So similar to using it for diabetes or weight loss, a lot of patients have a very difficult time tolerating the therapy due to a number of different GI side effects. If they do tolerate it, a lot of patients have had issues with insurance coverage or not having kind of the medication in stock. So they'll be on therapy and then they'll have a period of time where the pharmacy is out of it. So they've been off of therapy. But I would say those are the main challenges in terms of getting patients on it and getting them to tolerate it. Particularly for the semaglutide too, it's indicated at a specific dosing. And a lot of patients are on semaglutide for a different indication that's at a lower dose. And so it's not clear, if they're taking it at a lower dose, if it'll have the same degree of benefit from a liver standpoint.
All right. And, maybe the final few minutes in the podcast here, are these patients at an increased risk for acute coronary events? I mean, has that question even been asked? I don't know. I'm not familiar with data in this space and literature that is published in this space, which explores the intersection of acute coronary events and underlying MASLD. I want to surmise that maybe it's a risk factor or it's a risk enhancer at least, because like we mentioned, some of the risk factors are similar. Has that been explored, or have you seen that in clinical practice?
Another great point. Yes. So we actually spend a decent amount of time talking to patients, particularly patients who have kind of MASLD, not the more aggressive form. So there is actually a lot of data showing that the number one cause of death in patients who have MASLD is cardiovascular disease. The number two cause of death is cancer. And that generally has to do with the fact that, metabolic risk factors increase your risk of a number of different types of cancers, including breast cancer, prostate cancer, colon cancer. So the number two cause of death is actually malignancy. It's not until you get to the number three cause of death that is actually liver disease. So that is super relevant. So yes, if you're talking about competing priorities and what to be most worried about, by far and away, these patients tend to die from cardiovascular disease. In kind of partnership with primary care and cardiology, they're a lot more familiar with those conditions, and referring and medications as they are as compared to liver disease, right? Like I feel like people, and one of the challenges we're coming up against is people think like, oh, I only have liver disease if I have an alcohol use disorder, which is not true. And so people are not being screened for it. They don't know about it. They don't know how we should manage it. But yes, cardiovascular disease is a major cause of morbidity and mortality in these patients.
Excellent. Well, Monica, this has been a fascinating discussion. I've learned quite a bit on, and I feel more educated on MASLD. Is there anything you think we have not touched upon, which you think is important for our audience to know?
Again, I think we kind of touched the high points, and what we're really trying to focus on is one, right, disease awareness, both for patients and for providers. So, I think it's not well known that 30% of all adults in the United States have it. So it's a huge, huge problem. Two is knowing that there are existing algorithms and recommendations for who we should be screening. Primary care had a huge challenge with trying to grasp with who should I be worried about, what should I be doing. But now we have very well outlined kind of screening and risk stratification algorithms. We tend to reference the one by AASLD, but there's one through multiple different societies, including primary care societies, endocrine societies. I believe different cardiology societies have actually put out several kind of recommendations from this too, just because of the overlap in prevalence. And then really trying to not just screen for it, but to figure out how to get the patients that need to be seen to our clinic, which, as I said, we start with that FIB4. And then really knowing that now, as opposed to years ago, like we do have therapies for patients that have been shown to significantly improve fibrosis, and liver cell damage, was, as I said, are the things that track directly with outcomes. So it's super important now that we have therapy to really get these patients into clinics so we can get them on therapy and ultimately improve outcomes. But kind of to tie this all together for more of the cardiology audience, at the end of the day, still just in terms of outcomes, cardiovascular disease is the leading cause of death in patients with MASLD.
Wow, I'm glad that I could share this platform with you for our cardiology audience, and I think that we will. Certainly, I have become more aware of this comorbidity, which I'm sure now that my mind knows, my eyes will see, and we'll make appropriate referrals for our patients to be seen by hepatologists so that they can get the latest therapies that they deserve and therapies which will change the natural progression of disease. Monica, again, thank you for being a guest on Parallax. Thank you for educating us. And this is an evolving topic, certainly from a cardiologist perspective. I'm sure people have a lot to learn. For our listeners who've tuned in, thanks for tuning in every other Monday. Do share your feedback with us. We take it seriously. You can rate us or review us on Apple Podcasts, SoundCloud, Spotify, Google Play, Audible, whatever platform you use to listen to Parallax. If you have any questions for Dr. Monica Tincopa, please do send them to us and we'll make sure that we forward it to her and we'll get you her responses. And until other Monday, goodbye, everyone.
We hope you enjoyed today's podcast produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.